Welcome to POCUS Geek. I'm Jared Marks, and in this video today we're going to be talking about the utilization of clinical ultrasound, or POCUS, in acute renal failure. As in all these videos, I hope this is educational for you and hope you stick around to see how we can use this in our acute renal failure patients. When we talk about using clinical ultrasound or bedside ultrasound in the evaluation of the urinary tract, we have to keep in mind what utility it has. For me, when I think about it, I kind of think along these lines. Those that are cold are those topics which it's less useful, whereas those that are hot, I find it more useful. Now, there is some overlap from this. For example, you can see in hematuria that may be the first sign or symptom of a renal mass or cystitis or obstruction including kidney stones or ureteral lithiasis. And I think we have to keep in context that there's many pathologies out there that exist, these being some of the more common ones, and what utility clinical ultrasound has. Now keep in mind, we're talking about clinical ultrasound performed at the bedside by the clinician caring for the patient, not a consultative ultrasound where you order that test and they go off to radiology and have it performed by a sonographer, which is later interpreted by a radiologist. Instead, we are talking about what utility we can have to make real-time decisions at the bedside while we're caring for that patient. And the big thing for us with clinical ultrasound is that we're going to be looking for signs of obstruction. Obstruction, even in acute renal failure, is the key to what we're evaluating for. So we talk about classifying acute renal failure into three categories. We got your pre-renal failure, your intrinsic renal failure, and post-renal failure. Post-renal failure is going to account for up to 15% of all types of renal failure. And so while we're clinically taking care of that patient, that's going to help us know what to do with that patient. Now, for me as an emergency physician, that helps me know whether I need to be calling a medical team to care for the patient or possibly a surgical team, being urology, to further care for that patient in the emergent setting to relieve any obstructions that are causing that renal failure to occur. So if you get anything out of this lecture, the one thing I want you to remember is that the utilization of point-of-care ultrasound or clinical ultrasound in acute renal failure should focus on, and only focus on, post-renal failure. Now, there are some utilities of ultrasound. Maybe you want to know the blood flow to the kidney, but that, in my mind, is not a point-of-care ultrasound study. That is a consultative study that requires more time. Remember, when we're doing clinical ultrasound, this is a study that we have very focused binary questions that we're trying to answer, and we are not trying to just do that consultative comprehensive exam. Instead, we are very focused. And so I want you to remember that. And how I look at it is that using ultrasound creates a fork in the road. Either I go down one path or the other. And in this case, do I want to admit that patient to a medical team, or do I need to get them to a surgical team to relieve any type of obstruction that may exist? So that brings us back to reflect on what are the binary questions. So if you haven't had a chance to review the video on the anatomy, the sonographic anatomy of the GU tract, I would encourage you to go watch that. But this is taken right from that. And our binary questions really are, is there hydronephrosis and is there any urinary retention? That is what accounts for, what we're concerned for acute renal failure. These others, what else could be going on that you see below? Those are part of things we should, over time, be able to recognize, but not the focus, especially when we look at point-of-care ultrasound in acute renal failure. Instead, we should be able to look for those signs of obstruction. Maybe we recognize these. Hopefully we recognize those other things, but this is what we're wanting to do. Now, when we talk about obstruction, there's two kinds. There's unilateral or there's bilateral obstruction. Now, when we are talking about that is the hydronephrosis. So a unilateral should only be affecting one ureter, whereas bilateral should be is probably going to affect the bladder and everything proximal to that. So if we look at the anatomy here, we have our kidneys, which are connected to the ureters down to the bladder. And pretty much it's the same in male and female, with the exception, obviously, of the prostate, and that the urethra is a little longer in males. So when we talk about issues that develop, a bilateral obstruction will typically occur in males much more common than in females, significantly so. It doesn't mean that it can't happen in females, but when it does happen in females, we've got to be thinking about masses in the pelvis, or maybe atony of the bladder. But we'll discuss those a little bit more in depth here. So one of the most common causes of a unilateral obstruction is going to be ureteral lithiasis. So this would be a nephral lithiasis, or a kidney stone that has now traveled to the ureter and is in transit towards the bladder and becomes obstructed. There are 3 locations where a ureteral lithiasis can get stuck, and that is going to be the ureteral pelvic junction, also known as the UPJ. Additionally, as the ureter crosses over the iliac vessels, this is another common spot. And then probably the most common is going to be at the ureterovesical junction, or the UVJ. These will cause unilateral obstruction. Again, they can only affect one side. With that said, we have had clinical cases in our own emergency department where somebody has bilateral kidney stones passing at the same time. So that is quite possible, but not typical, and I would say that is the exception and not the rule. Typically, a kidney stone is going to cause, or ureteral lithiasis is going to cause, unilateral obstruction. Secondarily, this is probably more of a chronic cause for a patient, or a developed cause, but is going to turn into chronic, and that would be a stricture of the ureter. A stricture of the ureter is going to do the same thing as we can see here in this example. The proximal portion of the ureter is much more dilated on this side compared to the other, and that's going to be a more chronic issue typically, but is also something that could be leading to dysfunction and should be evaluated. Another example that can lead to unilateral obstruction causing hydronephrosis would be compression of the ureter. Probably the most common cause of this would be pregnancy. So in patients that are in 2nd and 3rd trimester pregnancy, compression of that ureter can lead to hydronephrosis, typically of the right kidney over the left. And this can lead to acute renal failure in our pregnant patients. This also could represent that they have external compression for an intra-abdominal mass. And so those are also things that we need to consider that could cause that unilateral obstruction. Now, when we talk about bilateral obstruction, again, earlier I mentioned that in men we have the prostate, which enlarges, and then that leads to dilation of the bladder, and then over time that could lead to bilateral obstruction or progression of that proximally and leading to bilateral hydronephrosis. In men, that is the most common cause, but it can happen to women, and if it's happening into a woman, then you need to be thinking that they may have a pelvic mass or structure. And that brings us to the last one. So I mentioned pelvic mass or structure, but you could also have atony of the bladder or dysfunction of the bladder that could lead to bilateral hydronephrosis. And so those would be the things that you would want to consider in that case. So with that said, we should look at how we classify hydronephrosis. So if we think of the kidney looking like this, we're going to strip away we're going to cut that cortex in half, and we're going to come down to the middle. And we'll see our renal pelvis and our renal vasculature. And just for educational purposes, we're going to imagine that our renal vasculature is not there, and we're going to only focus on this renal pelvis and the degrees of what we would see in hydronephrosis. So just keep in mind that the kidney itself does not grow, but it's the matter of distension that happens within the ureter and the renal pelvis. And, if we catch this early, the earliest thing we will be able to see is hydroureter. And this will show up as an anechoic space or black space on the ultrasound that is in that proximal ureter and may extend slightly into the pelvis of the kidney. If that progresses or worsens, then it could lead to mild hydronephrosis. Now, mild hydronephrosis, by definition, should only fill the renal pelvis somewhat, should not be affected up into the calyces, and would only distend that somewhat. I think that when it's at this stage, it can be hard to determine if that is hydronephrosis versus a vasculature that's in there. So sometimes you may find the use of color Doppler useful to determine if that is a blood vessel versus hydronephrosis. If that progresses, then we have development of moderate, and moderate should get down into the calyces and could potentially start to affect the renal pyramids, and that's when we would consider it a moderate amount of hydronephrosis. To me, anything moderate or below is not always as quite as emergent, but should be addressed. When we get to severe, that is where we start to have compression of the renal parenchyma. All of these are important when we, for example, if we take ureteral lithiasis into consideration, maybe without acute renal failure, that a person with moderate or mild hydronephrosis could go home. In fact, we discharge many of these as long as their symptoms are controlled. But any person with severe, that should get further evaluation, whether that be with CT or a urology consult. But that should be a focus that we have. Severe hydronephrosis should really, raise your awareness or your concern for that patient. So again, I'm just going to come back to this. Utilization of clinical ultrasound or point-of-care ultrasound in acute renal failure should focus on the causes of post-renal failure. So what we're going to look at is we're going to look at those kidneys and determine if they are developing hydronephrosis or not. If there is hydronephrosis, that may require further studies, whether that be a CAT scan, CT scan, or evaluation by our surgical colleagues. That is something to consider. Now, one thing, I want to go through some pearls and pitfalls. So ultrasound should be your go-to for evaluating for obstruction and acute renal failure. If we look here, 1 to 3 cases of AKI or acute renal failure in the ICU is going to occur due to obstruction. Now, maybe the Foley's blocked, maybe they're not urinating. That might be more of a bilateral, less likely to be a unilateral, but could occur. And then when we look at non-ICU cases of acute renal failure while in the hospital, or even just community causes, we're looking between 10 to 15% causes for acute renal failure. Another thing to keep in mind, that hydronephrosis may be absent in volume-depleted patients regardless of what type of hydronephrosis or cause they have. So whether that's a ureteral lithiasis or a mass, if they're volume depleted, that may not be as apparent. There is some data out there to say that if you give them a 500 ml bolus of fluid, that will make the hydronephrosis appear. And that is what I typically do in my practice to evaluate for hydronephrosis if it is absent when I suspect it to be there. Now, that is independent of acute renal failure patients, but a lot of times when we have acute renal failure patients, we do give them fluids, and it should be a consideration that you reevaluate them to see if hydronephrosis is developed, if initially not present. Another thing to keep in mind, that kidney parenchyma may itself, now we're talking outside the renal pelvis, may become more hyperechoic. This doesn't, however, tell us what kind of acute renal failure is present, but that may be one thing that we recognize. Now, the hard part is if they're having acute renal failure, it's typically affecting both kidneys when we're seeing it in the labs, and may not be as obvious to us when we look at an individual patient. But keep in mind that it could show up as being hyperechoic. It is quite specific, has a moderate positive predictor value, but something that you may see. Now, again, this is not a binary question we have, but it is something we may recognize when performing this study. Another additional thing is we may stumble across patients with chronic kidney disease. Maybe they have not had any care and they show up and they have a creatinine of 3. We may recognize that they have smaller kidneys. Now, kidneys less than 9.5 centimeters in length are likely abnormal. That's probably been abnormal over time for them and may represent chronic kidney disease over an acute renal failure. Now, the overall volume of the kidney is important, but again, that may be Beyond the scope of clinical ultrasound is where they're at the bedside and may require further tests, but that is one thing that we could recognize, is that the kidney length is not normal. Keep in mind that the normal kidney length is typically between 10 to 12 centimeters in most individuals. Here are some references in regard to the use of clinical ultrasound in acute renal failure and its utilization. Some of them are also considering consultative ultrasound, but hopefully you'll find these useful. I'll put those down in the video description below so you can have access to those, and hopefully with some links. Thanks for joining us here at POCUS Geek. If you have any questions about this content, please feel free to reach out. You can reach me at pocusgeek@gmail.com. Hopefully you found this educational and can incorporate that into your clinical practice.